All right, guys, welcome back to Underground Science. In this video, we'll be talking about tricuspid atresia. Okay, so tricuspid atresia is actually a cyanotic, all right, cyanotic congenital heart defect. And in this disease, the main idea to keep in mind is that you don't form the tricuspid valve, right? So that's what tricuspid atresia is, but we have to go see why that's bad. Why is it bad that you don't form a tricuspid valve? Right? So let's just go and talk about that real quick. So normally, right, let's talk about the pathophysiology. But before we do that, let's talk about the normal blood flow through the heart really quick, right? So normally we know that deoxygenated blood, all right? So deoxygenated blood comes to your right atrium. Then from there, it goes through your tricuspid valve to your right ventricle. Then from your right ventricle, it goes through the pulmonary valve to your lungs. And then from your lungs, oxygenated blood now comes to your left atrium via pulmonary veins. Then oxygenated blood from your left atrium goes to your left ventricle via the mitral valve. Then this oxygenated blood from the left ventricle then goes to the aorta, right? Through the aortic valve and then to your body, right? And then it delivers, and then your cells pick up the oxygen, and then it loops back around as deoxygenated blood and comes back to your right atrium and keeps on cycling like that, right? So that's the normal blood flow through the heart. In tricuspid atresia, what happens is, right? So in tricuspid atresia, what happens is deoxygenated blood arrives in your right atrium. Then from your right atrium, the deoxygenated blood tries to go to your right ventricle, but it can't, right? It cannot go to your right ventricle because there is no tricuspid valve that's formed, right? So then that means two things, right? One is blood is never going to your right ventricle, which means there is no blood going to your lungs, which can be deadly right away, right? Because there's no blood being oxygenated then. And the second thing is, if there's no blood going to your right ventricle, that means that your right ventricle will atrophy and become hypoplastic, right? If you stop working out and you don't use your muscles at all for years, right? Let's say, then you'll notice a significant atrophy in your muscles because of the use it or lose it principle. Same thing goes with your right ventricle muscle, right? The myocardium of your right ventricle will atrophy if you don't use it. In this case, there is no blood that the right ventricle is receiving because there is no tricuspid valve. So the blood in the right atrium cannot make it to your right ventricle. So then your right ventricle isn't pumping any blood to your lungs. So it's not using its muscle, its myocardium, to do any work. So it's going to atrophy. Okay, so that's one thing you can see is a decreasing size of your right ventricle and a hypoplastic right ventricle specifically. Okay, so one thing to note though is that, okay, so we said that the right ventricle is hypoplastic, which makes sense, right? So let's redraw the heart like this. So we know one thing for sure now. We understand that, okay, blood is not making it down to the right ventricle. There is no tricuspid valve. Then how does blood make it to the heart? Okay, so what we need to do is we need to get the blood from the right side of the heart to the left side. And the reason why this is crucial is because we need some sort of blood to be pumped to the systemic circulation, right? So that's the first thing we need to do, and that's why usually this tricuspid atresia is usually associated with an ASD, which is very helpful because now blood can make it to the other side of the heart, right? And so then you can ask, okay, why is that important? Well, now let's see, right? So now you have deoxygenated blood that just made it to the left side of the heart, right, in your left atrium, and this is deoxygenated, which will represent like that with a D, right? This deoxygenated blood will then go to the left ventricle and then get pumped out to the systemic circulation through the aorta, right? So it's going to get pumped through the aorta to the body. That's why you see cyanosis, because remember, you have the lungs here that's returning oxygenated blood to the left atrium, but then you have this ASD here that's allowing mixing of blood. So you're getting deoxygenated blood, right? That's mixing with the oxygenated blood that's coming from the lungs via the pulmonary veins into the left atrium. So that's why you get cyanosis. Okay. That's why this is a cyanotic congenital heart defect. Okay. So you get cyanosis this way, but we still haven't got any blood to the lungs, right? There is no blood going to the lungs. So like how is that supposed to work? So the way this works is we either need a VSD, right? So that blood can go from your left ventricle to your right ventricle, and then from your right ventricle to your lungs, right? So you can get some blood that gets oxygenated at least, or you need a patent ductus arteriosus, right? So what are the two ways we can get blood to the lungs? Okay, so we have this right here. We know now that we have an ASD, right? And ASD is associated with tricuspid atresia. So this allows deoxygenated blood to cross over, go to the left ventricle. Okay, so now we're here where we have mixing of blood we're in the left ventricle right now. So how do we get blood to the lungs? One is that we have an associated VSD with this disease, right? Where now we can see that this blood that's in the left ventricle can cross over to the right ventricle, then go to the lungs, right? Then get oxygenated and then come back to the left atrium. Or we can have a patent ductus arteriosus, where we get blood that's in the left ventricle. It gets pumped to the aorta like it normally does, right? Like the heart normally does. And then if we just zoom in on the aorta here, right? And then we know we have our three branches here. After our left subclavian branch, we have our PDA, right? Our ductus arteriosus. If we remember that this is let's say we draw it in a different color right here. So this is going to be our pulmonary artery right here. Okay, it's inserting. There's an opening between the aorta. So let's complete this aorta drawing, right? There's an opening between the aorta and the pulmonary circulation, the pulmonary artery specifically, right? This is our pulmonary artery. This is our aorta. And this is we know our brachiocephalic trunk, left common carotid, left subclavian, right? So after the left subclavian is the opening of the ductus arteriosus, where blood that gets pumped into the aorta, right, can cross over and enter the pulmonary artery. Now, in utero, right, because the pressure in the lungs is so high, we get the opposite flow, right? We get blood going from the pulmonary artery to the aorta. But after birth, we know when the pressure in the lungs drop, right, then the blood flow switches, where now the lungs are low pressure. So then blood in the aorta gets shifted over to the pulmonary artery if the ductus arteriosus stays open, which is going to be called a PDA, right? So we need a PDA in order for blood to go to the lungs, or we need a VSD like we discussed before. Okay, so that's the two ways we can get blood into the lungs. We need a VSD or a PDA. All right, so now that we got that covered, right, and we understand that, let's talk about something else that's very important. Okay, so now what do we know, right? Let's do a quick recap. We know that tricuspid atresia means you don't have a tricuspid valve, which means that the right ventricle is not pumping any blood. So it's going to be hypoplastic and small and atrophied. This also means that we also know that this is associated with an ASD, right? Which means that we get mixing of blood into the left side of the heart, which means we're going to see cyanosis, right? So we know that we see cyanosis and we see a hypoplastic right ventricle. And we also know it can be associated with a VSD or a PDA, right? Those are the only two ways where we can have survival and we can have blood going to the lungs. A VSD allows blood to go from the right side to the left side, so right to left shunt, right? Or the left to right, to the left side of the heart to the right side. So we see a left to right shunt with a VSD, right? And that allows blood to go to the lungs. Or we can see similarly a left to right shunt, but involving a PDA, right? Which also allows blood to go to the lungs. And then of course, we said we also have an ASD, which would be a right to left shunt. right? So now that we have that in order, and now that all that makes sense, let's talk about something else. So remember, the left side of the heart, right? Let's say this is our ASD. The left side of the heart is getting blood from the right side. So all the blood that's entering the right atrium, right, from the veins, deoxygenated blood, that's getting shifted over, right? And then we said, remember, the lungs also are returning blood to the left side of the heart. So not only is the left side of the heart getting blood from the systemic veins, right? It's also getting blood that's returning from the heart, the pulmonary circulation. So then that means the left heart will get overloaded. So we can see, since all this blood is coming to the left atrium, one thing you can see is the dilation of the left atrium, right? And then all that blood, right? Not only the blood that's coming from the lungs, but also from the right side of the heart, all of that blood is going to the left ventricle now. So the left ventricle is going to pump way more blood than usual with every heartbeat. So we can see left ventricle hypertrophy, right? Left ventricular hypertrophy, which is not good in the long run because that can lead to heart failure, right? And another thing we can see is because there's no tricuspid valve, the pressure in the right atrium can start to rise, right? Because not able to pump blood to the right ventricle. So something we can see is right atrial dilation also, right? And potentially, if it worsens too much, blood can start backflowing, and you can see things like JVD, edema, right? Hepatomegaly, things like that, right? That's something you would see in a right heart failure also, but that's advanced, right? Like that's not that won't happen right away. But the main findings that we need to know is the fact that both your atria can dilate and your left ventricle can hypertrophy. And your right ventricle is going to be hypoplastic. You can have an ASD, a VSD, or a PDA, right? VSD or PDA is crucial in terms of getting blood to the lungs, right? And an ASD is crucial to getting blood to the left side of the heart. So you can get it pumped to the systemic circulation. Now that we have a good understanding of what tricuspid atresia is, right? One thing we can reason through is because because it's going to be cyanosis, we're going to get mixing of blood, and the blood oxygen levels will be lower than normal, right? What your body will do in response to that is make more red blood cells in hopes of delivering more oxygen to your tissues. So you can see an increased red blood cell count, right? Or an increased hematocrit, right? Polycythemia. Because we know in response to low oxygen, your kidneys will release EPO, right? Erythropoietin, which will go to your bone marrow and tell it to make more red blood cells. Okay, so that's one compensatory mechanism that we may see. And over time, this chronic hypoxia, if not corrected, right? This chronic hypoxia, this chronic low oxygen delivered to your tissues, right? Over time, that can lead to something called clubbing, right? And you can see this in other disorders that has chronic hypoxia in it, right? Certain lung disorders. So you can see clubbing of your fingers, right? So that's one finding that you can see. And then, of course, if you test with a pulse ox, you can find lower oxygen sats, right? Low O2 sats. And then there's a question that comes to mind is if you give high flow oxygen, right, to a non breather, for example, will the blood oxygen levels correct, right? So we can actually reason through this. So if you're giving high flow oxygen to the infant, right, let's say to the newborn, and the oxygen levels, will it correct or will it not correct, right? So if we see this, right, so you're giving oxygen, it makes it down to the lungs, okay? And then from the lungs, we know that if we zoom in, we have alveoli. From the alveoli, it'll go to your pulmonary vasculature, right? So now we have O2 in the pulmonary vasculature. Now, where does blood go from here? It goes to the left atrium, right? Via your pulmonary veins. So now we have oxygenated blood, right? We're giving high flow oxygen to the newborn. right? And then we have oxygenated blood in the left atrium now. But then remember, we have an ASD. So the right atrium right by it is sending blood over. Now, what kind of blood is the right atrium sending over? It's sending over deoxygenated blood, right? So no matter if you're giving 100% oxygen, right, we're still going to get mixing of blood because remember, we have this ASD, which is a right to left shunt, right? The right side of the heart is receiving deoxygenated blood from the systemic veins. So no matter what, you're still getting deoxygenated blood shunted over to the left atrium. So then that's mixing of blood now. So you're going to have lower oxygen sats, and you're going to have that mixed blood, right? That doesn't have as high of oxygen anymore. That blood is going to be pumped to the systemic circulation. So no matter what, you'll still see low oxygen sats, right? Giving 100% O2 doesn't significantly improve saturation because of this right to left shunt. Okay, so that's one thing to keep in mind also. And of course, certain symptoms that we should talk about is we already talked about this. You'll see cyanosis, right? Because of the mixing of blood. And because of that, what we can see is difficulty breathing, right? The newborn can have significant difficulty breathing depending on how severe this is, right? So you can see difficulty breathing. And then, of course, you can see fatigue, right? Failures to thrive because of the low oxygen levels. And then something interesting to keep in mind is when we're talking about murmurs, remember a VSD does give off a murmur. The smaller the VSD, the greater the intensity of the murmur. The bigger the VSD, the lower intensity of the murmur. That's something to keep in mind too. A VSD usually gives off a holosystolic murmur, right? So you're going to hear that murmur throughout S1 and S2. So it's going to be a holosystolic murmur. And then remember, your right ventricle is hypoplastic, right? You're not pumping any blood from the right ventricle to the lungs. So your pulmonary valve isn't really going to give a sound, right? So you're only going to hear a single S2 sound, right? And that S2 sound is going to be your aortic valve closing, okay? So that's something to keep in mind also. Now, of course, if you have to diagnose this, a really good way would be to do an echocardiogram where you can actually see that, okay, you can actually see the absence of the tricuspid valve and the hypoplastic left ventricle, right? So in here, you can see the absence of the tricuspid valve, and you can also see the hypoplastic right ventricle, right? So then that can tell you about, okay, there's tricuspid atresia present, right? And of course, because the left ventricle is doing most of the work, you can see something on the ECG called left axis deviation, right? And that just, and you can also see left ventricular hypertrophy, right? On the signs of left ventricular hypertrophy, just because we discussed that the left side of the heart is getting blood not only from the lungs, but also from the right side via the ASD. So left ventricle is doing way more work than usual, which can lead to hypertrophy over time. And then, so those are main imaging findings to keep in mind, right, when talking about diagnosis. And then let's talk about treatment now. So we know normally, right, when the baby is born, then pressure in the lungs drop, right? And when that happens, because of the first few breaths that the baby starts to take, the pressure in the lungs drop and oxygen levels go up, right? And due to those factors, your ductus arteriosus starts to close, right? That's the normal process, right? So oxygen levels start to rise, the pressure in your lungs drop, and then your ductus arteriosus starts to close. Now, if you give prostaglandin E1, right? So prostaglandin E1, what this does, it actually doesn't let the ductus arteriosus close and keeps it open. Okay. So prostaglandin E1 actually keeps the ductus arteriosus open. All right. And that's really important because that can be one of the treatments, right? At least that can be one of the treatments involved in immediate care before surgery occurs. Because remember, if the ductus arteriosus is open, then that means blood from the left ventricle can go to the pulmonary artery, right? So we have that blood flow going to the lungs, which is very, very important. And then afterwards, then surgery can be considered, right? So what are some surgical processes that can occur? Okay, so one surgical process that can occur is going to be involving the superior vena cava, right? So the superior vena cava actually can get attached and get connected to the right pulmonary artery, right? So if the superior vena cava gets connected to the pulmonary artery, that means that blood from the superior vena cava, right, deoxygenated blood, instead of entering the right atrium, it's going to enter the pulmonary artery directly. Okay, so we're going to get that blood flow going to the lungs, right? So we can get blood that can get oxygenated properly. Okay, and what this also does is it reduces the volume load on the left ventricle because now the left ventricle isn't going to be getting blood directly from the superior vena cava, right? Because usually the superior vena cava would dump its blood into the right atrium, plus the inferior vena cava would dump its blood to the right atrium, and then the ASD would make all this blood go to the right to the left atrium, right? And remember, the left atrium's also getting blood from the pulmonary veins, right? So the left side of the heart is getting overloaded. But now, because of this one of the surgical procedures where you can attach the supravena cava to the pulmonary artery, right? So now that reduces the volume load of the left ventricle because now the left ventricle is only dealing with blood that's coming from the inferior vena cava and the pulmonary veins, right? Not the superior vena cava, right? Because now the superior vena cava isn't dumping blood into the right atrium, it's dumping blood to the pulmonary artery, right? And then we know the pulmonary artery, that blood goes to the lungs, gets oxygenated, and then comes back around to the left side of the heart, right? So that's one procedure that can occur. Another procedure that can occur is something called the Fontan procedure, right? And in this, you connect the inferior vena cava to the pulmonary artery as well as the superior vena cava to the pulmonary artery. So now, right, you're getting both the big systemic veins dumping its blood into the pulmonary artery. So you're getting that passive blood flow to the lungs. And so, and all that blood, of course, then can get oxygen and return to the left side of the heart. And the left ventricle can pump that fully oxygenated blood to the body, right? So your cells can get proper amounts of oxygen. Right. So in this Fontan procedure, then your right ventricle isn't, doing much of a job, right? So because most of the blood is going straight, not into your right side of the heart anymore, it's going to your pulmonary artery. Okay, so your right ventricle is not really pumping much blood or doing any work to pump any blood to the lungs. It's just coming directly from the superior and inferior vena cavas. Okay. So those are some procedures that can occur, and that counts as a treatment, right? And that's basically what tricuspid atresia is. Okay, the main thing to remember is there's no tricuspid valve, and then from there we can always reason through what happens next and what symptoms we see, right, and make sense of it that way. So that was basically tricuspid atresia. Hopefully that made sense, right? And thank you for watching, and see you guys in my future videos.